Good morning. I am going to record a section of this week two content. So I know that we're going to cover schizophrenia and we're going to cover personality disorders, and those are two very big topics. So I wanted to just do a small little lecture on the somatic symptom illnesses, just because I think it's easier for your brain to wrap around those two big concepts, and then you can get to this one when you have time. So this is actually a part of the PowerPoint presentation that goes along with schizophrenia. Um, so it's going to come right in line. But I wanted to make sure that we kind of had a chance to talk about it. So when we talk about somatic illness, we're talking about the mind body connection is what we're talking about. And because of that, I want to show you just a quick link that is going to kind of discuss what we sometimes have glossed over, I guess, in the community of Western medicine. So this just kind of gives us a history of where the topic of psychosomatic came from, and kind of we'll build on that.
Psychosomatic means mind and body related. The term merges the two Greek words psyche or mind and soma or body. A psychosomatic disorder, then, involves both mind and body. It is said that the foundation for psychosomatic movement was laid 2,500 years ago in ancient Greece. Back then, physicians who contributed to the Hippocratic Corpus, a collection of around 60 early ancient Greek medical works, described psychosomatic disorders in terms similar to those used by modern medicine. A psychosomatic disorder is caused or worsened by mental factors. For example, people with severe depression often stop taking care of their physical needs, like eating, sleeping, and personal hygiene, and become physically ill as a result. The term is also used when mental factors cause physical symptoms, but where there is no detectable physical illness. For example, chest pain may be caused by stress, even when no physical disease can be found. There is a deep connection between beliefs, thoughts, and emotions, and physical problems in the body. As a result, there are hundreds of illnesses that are purely psychosomatic or have a psychosomatic component. Despite the prevalence of these disorders, the medical community has been slow to embrace the importance of the mind body connection. Long before philosopher Rene Descartes claimed that the mind and body were separate entities, a philosophical dichotomy in Western medicine between mind and body existed. Until recently, Western medical practices have tended to treat mind and body separately. However, in the last few decades, an emphasis on the mind body connection has developed. Doctors today often recognize that emotional factors play a role in physical symptoms experienced by patients, and that these may be related to interdependent factors, including biological, psychological, and environmental factors. Psychosomatic medicine borrows from Eastern traditions that view body, mind, and spirit as inseparable by utilizing activities such as meditation, yoga, breathing, and visualization techniques to elicit awareness and relaxation responses. It has provided a comprehensive framework of reference for several current issues of clinical medicine, including the current dialogue with mind body medicine, which shares the same holistic approach, incorporating biological, psychological, and social factors. However, unlike psychosomatic medicine, which has always been marginal to the lay public, mind body medicine has been greatly effective in popularizing key psychosomatic concepts that embrace care and education for physical, mental, emotional, and spiritual health.
Sorry, that was a little trippy, but I think we need to in order to frame this topic correctly, I think we have to have conversation on what that means, the mind body connection. So since COVID, we have seen a lot of literature and a lot of infomercials and a lot of TikTok and things like that that focus on mindfulness, right? The concept of mindfulness and the concept of reflection and meditation and self-care. And all of that kind of ties together in what we're talking about here. Okay. So I want to make sure that we kind of frame it the right way. And if we were in person, maybe we'd have a good conversation about this. But I want to at least set the stage. So that first video we watched, the history of psychosomatic, of how it's kind of interesting that we viewed mind and body separately, and then now we're trying to hold it back together when originally it was one concept, right? Like there was a yin and yang and it was all together, and then we separated it. And now we're trying to figure out and put it back together. The second video that's on here that I'm not going to show you has to do with somatic illness and what it means. So this is like a quick and dirty, like 4-minute explanation. It's a good review of everything we're going to cover in the PowerPoint. Okay. So what does it mean? It is when the mind is producing bodily symptoms. Okay. So this may be making something that you already have worse, or it could be creating something. Okay. So somatization is what that is called. So three different things is what we really see. We either see, um, we see a physical condition, right? We see something going on symptoms wise, but there's nothing really causing it. Like every CAT scan looks good, the blood work looks good. We see psychological factors, right, that make it worse or keep them from getting better. So maybe there is an issue, right? Maybe there is a problem. Maybe it's chronic pain. Maybe it is a chest pain, something like that. But because of the psychological factors, the mind is preventing the body from healing. Okay. It's keeping those symptoms going. It's starting them. It's keeping them. It's making it worse. So there actually is some connection, right? We see something. And the third one is that everything is magnified, right? So everything is magnified, but it's not under their control. And that's the main thing we need to think about is we always talk about self-reflection, right? Knowing ourselves. So we're talking about things that this is not somebody wanting to be sick, right? This is not somebody who wants anything to be wrong with them, but there's a disconnect and the mind and the body don't talk to each other. So if you ask them like, are you faking? No, you're not faking it, but you're something is happening with your brain, so it's causing it. If you want to do a deep dive into something that's really interesting, so your book touches on the concept of hysteria, and it's really interesting what that meant. Hister obviously talking about the uterus. And so this is what a lot of in the past physicians would diagnose women with hysteria, right? And so they didn't have a reason for why they were having things like panic attacks or anxiety or physical symptoms or fainting. And so they thought that clearly the uterus is the source of all evil, right? In women, and they thought it was floating within the body. And so they thought that the hyster, right, the uterus, would then float underneath the lungs and cause them to be short of breath, or would float under the diaphragm, right, and would cause them to pass out. So we don't use this term correctly, right? So we say someone's hysterical, right? It can be hysterical laughing or hysterical crying. It's basically like out of control almost. What it technically means, right, and what they used to call was that this hysteria was kind of not able to explain any other way, but the women just were not portraying the way that they thought they should. In your book, it talks about multiple physical complaints, and the same thing, no basis, right? They thought it must be a wandering uterus that's the problem, but really, it's we just don't know, right? So all of this to say that. Okay. This is not something they're doing on purpose. This is not them trying to manipulate the system. This is not them trying to get someone to acknowledge them. It truly is an illness of the body and the mind, but they're not connecting. Okay. So we have to get into the mind of our clients, our patients, and say, this is not anything they're controlling. Okay. We're going to talk about a couple disorders that you may see or pieces and parts of it, right? Not everybody presents the same way. So you might even see just a fraction of this. What might you see? All right, here's 5 things. You might see vague symptoms, right? Or they might be overly exaggerated. They might fixate on one thing, right? So their whole life revolves around their fixation with their symptom, with their pain, with their whatever, right? Anxiety or depression oftentimes go hand in hand with this, right? So if you're fixated on this symptom that you can't find anyone to give you a reason why you have it, it will lead to anxiety and depression. It very easily can. Um, they may get a diagnosis and they might not agree with it, right? And so they're going to go to 4 or 5 different doctors. So if you have that client, you go in and they have all these things that we mentioned, and then they're talking about this opinion and this specialist and that specialist. Maybe they've been going to multiple providers, right? And this leads to, if we kind of go in a circle here, this leads to long-term use. We may say abuse, but long-term use of healthcare resources, right? For this thing that either they've been told it's something and they don't agree with it, or no one can diagnose it, right? And they become anxious and they become depressed, and it affects more of their health, right? It's that vicious circle. So, what type of things can there be? All right. So, somatic symptom disorder, we talked about that. Symptoms that you go through the CAT scanner, you get the blood work, you get the x ray, and there's nothing there. We're going to talk more in depthly about this functional neurological symptom disorder. Your book also mentions it used to be called conversion disorder, and you may still hear people say that. And that is a total, it affects the whole body and it's unexplained. And it starts and it just steamrolls. It starts with one symptom, and then very quickly they're not able to walk, they're not able to control their body, right? And it is a neurological disorder. Okay, we'll talk about that one. Pain disorder. Um, if I was in classroom, I would ask you to raise your hand if you have heard of fibromyalgia, right? Um, that is what I think we've all heard of, right? Fibromyalgia. And that is literally pain, like unexplained nerve pain is what it is. Now, there are some in the healthcare community who think that fibromyalgia is a somatic disorder, right? It is not something you can see. It is not something that you can get it's a diagnosis of exclusion, meaning you've tried everything, you can't find a diagnosis, and so you're treating the symptoms. But there's some people who think that it's not real, right? I used to work with a physician of the nurse, and he would say to his patients when they would come in and he would, be getting their medical history, and they would say this whole long list of things that they'd been diagnosed with. And then they would say, and I have fibromyalgia. And he would roll his eyes and he would say, of course you do, right? Because it's not real. And then he would say something to the patient like, oh, is your fibromyalgia end stage? And of course, there are no stages, right? But that was just his way of kind of digging in. And then they would kind of either be completely confused and say no, or, they would, yeah, I think it is end stage. But it was just a way to express his belief, I guess, that it was not real. And I think it's very easy when we have these patients that come in and they're super needy and they're super um, wanting to tell you their health history and wanting to just bore you with these details. We have to, I mean, I know we're busy, right? We have 1,000 things to do, but we need to understand that by being dismissive, by ignoring, by making fun of, by teasing, by doing these things for these people, we are just making their anxiety worse. We are not acknowledging that this mind body connection is sometimes very, very real and out of their control. Right. And we're talking about personality disorders. We're not talking about borderline. We're not talking about attention seeking behaviors. We're talking people who truly have a somatic illness. Okay. The the illness anxiety disorder, or health anxiety disorder, right, is what you'll hear it called. We used to call this hypochondria. And I think everyone has kind of heard of that. That is where you have a fear of or a preoccupation of getting a serious disease. Okay. You'll notice that they have formally for two of these. And that is because as we have gotten more educated, we're starting to realize these things in a different way. Okay. We'll talk more about these. So, what are the risk factors for developing these somatic illnesses? So, if you have a family member, a first degree relative who has it, if there is an imbalance in your serotonin or your endorphin, if you already have a depressive disorder or a previous anxiety diagnosis, if you have a trauma, right? If you've been abused, neglected, or if your social situation, your social awareness has provided you with some degree of learned helplessness, meaning that you need someone to do things for you because you do have some type of infirmity. Okay. In your book, on page 408, before we go a whole lot further, I do want you to go in there and look. And if you have the old edition, maybe it's not page 408, but basically, I want you to look at some cultural considerations, right? So sometimes in other cultures, these somatic mind body type things are accepted. They are, they have a specific name to them, and there's a way that's embraced in different cultures. So before we slap our label on it, we do need to look at their culture. We look at their background, right? Is this something that in their, you know, heritage, this is something that's a rite of passage? Okay. So take a look at that as well. Where does this come from? This somatic illness. Okay, so there's several things. But one of the key things is internalization, right? We don't talk about our feelings, right? We in healthcare are very good at that. Like we stuff them way down and we don't talk about them. So by having feelings, by experiencing different emotions, but not talking about them, keeping them inside, it will eventually take a toll on you, right? Whether you become depressed, or you become angry, whether you get poor coping mechanisms, right? Or you could develop some type of a somatic illness where your brain and your body just like they just quit talking to each other because you're not acknowledging and dealing with what's going on. Some of these people don't aren't able to express. Maybe it's they want to express what's going on, they just don't have the tools to do it. um we do need to understand that these individuals, they have difficulty with conflict, right? They have been dismissed, they have been teased, they have been ignored in their mind, and so they have been told over and over they're attention seeking or they need to be sick, right? And in reality what it's doing is it's letting them have some type of need met, some type of emotional need. So depending on what's going on with the need, with the brain, with the stressors, with the situation, this could be chronic or it could go away and get better, and then it may come back and reoccur. Okay. I keep moving myself to the side here. So what are we going to see? We're going to see symptoms. We're going to see their lives upended. They're going to have something that is getting in the way of them doing the things they normally did, either how they used to be or they are now adjusting to this new normal. Okay. And that caused them to think about it all the time, right? You're always thinking about what you used to be able to do. This makes anxiety, this makes it worse, right? Again, they could sometimes have coping mechanisms like alcohol or substance abuse or use to try to balance it. Okay. They may take too much medicine. They may take too much Tylenol. They may take too many of their anxiety medications, which may lead to other issues. Okay. They may be going to different places as their symptoms kind of get better and worse. Okay. There's a screening tool that's called the PHQ-15. Okay. And this has to do with your somatic symptoms. Now, in your book, there is a box 21.1. I want you to look at that. Right. And that's going to give you a much better picture of what some of these mean and how they present themselves. But I just want you to know that there are tools. This is so common. There's tools that we use to try to see, like, how bothered are you by these symptoms? Okay. So just be aware of that. What's our treatment? How do we fix this? So our goal is ultimately we want to get the symptoms down low enough that their quality of life gets better. That's our goal. I mean, that's our goal with every patient, right? Is we want them to have positive patient outcomes and good quality of life. We can use antidepressants, right? And again, this is where fibromyalgia sometimes will be thrown in this category because one of the medications we use to treat this is antidepressants, right? So look at the SSRIs. Take a look in the book. It's got a list of different medications that may make it better. We might treat some underlying cause that is then manifesting itself in bodily symptoms. We want to make sure we are empathetic and that we are sensitive. We want to involve other teams. We want to use pain management. We want to use community support and resources. And we want to make sure that they're not just pacifying themselves with pain medicine, right? Or some type of medication, anti-anxiety, Valium, Ativan, something like that, that's just going to numb it, right? And not address the core of it. Okay, so our nursing care needs to be multifaceted. We need to accept and extend our understanding that this is real to them. Remember, pain is what they say it is. These symptoms are what they say it is. We want to make sure they're safe. because if they've been dealing with this, they feel dismissed, they feel nobody's listening to them. It can increase the risk of self-harm and suicidal ideation. We want to set boundaries, right? And I didn't separate and I didn't highlight that one in a different color, but we definitely do want to establish boundaries. We don't want to get sucked into a 4 hour conversation on how your hemorrhoids are doing, right? I know they're real to you, and I know the pain is real. We do have to set boundaries, okay? So a little bit of tough love in that we're encouraging them to be independent. We're encouraging them. I understand. We'll talk about it. Here's the amount of time we'll talk about it. Now let's talk about what you are able to do, right? And let's encourage that independence. We want to have them talk about their feelings. We want to make sure that they have coping techniques, right? Deep breathing, visualization, meditation, whatever works for them. And then we want to make sure they're physically active because if they become bedbound and depressed and they kind of shrivel in, then we've got muscle loss, right? And then we have loss of function. So a big part of this is we want to make sure there's a case manager assigned to them. Because if there's somebody making their appointments and making sure that they are aware, yep, we hear you and here's your plan that we have set out for you, this can decrease the number of times they're calling doctors' offices, right? Bouncing around to different places and kind of sucking up more healthcare resources when we've got a plan set out for them in your book, right? In your book. And I know there's a lot to read in your book. So dial in on this pink pages, right? All these pink pages are care plans. And they have two in there on this topic. One is on the functional neurological disorder, and one is on the hypochondria or the illness anxiety or the health anxiety. Okay, so take a look at those. Um, but we have to say we are human, right? We are human. And we need to know that we're going to be frustrated with these patients, right? So we need to know what our limit is, what our boundaries are, and make sure that we are taking care of ourselves as well, because this can be frustrating, right? Pouring out empathy into a patient who is just like soul sucking, right? We do have to understand that. We need to validate their feelings, but then we also need to be realistic on what are our expectations for our patient, right? What are the things we're going to be able to do? We're not going to beat our head against a wall, but we are going to start getting some small successes here to try to get them over the hump and get some movement, get some independence going. And we just it's so easy to say like, oh my gosh, if they could just do it, they just suck it up and do it, right? You could do it if you just tried. And that's a very real frustration for these people because biologically, physically looking at them, looking at the test, there's no reason why they're not fully functional. And so it's very frustrating for us. It's like I've got four other patients that need me because they really can't get out of bed. And you could get out of bed, you know? So this is where we need to take a breath, take a refresher, get in the right frame of mind. Tell your buddy, I'm going in 15 minutes. You know what? Hit my Vocera and call me out of there. Um, so your patient is getting the best of you, but you're also able to like manage your day. Um, I hope that makes sense. And I hope that means I hope I'm painting it in the right light. But this is draining. It is draining. I'll be completely honest with you. But we also have to do the best we can for our patients, right? So this illness anxiety or health anxiety, we used to call hypochondria. And this is, I think we've all had experiences with family members. I know when I first started nursing school, I started hearing about different things like maybe I have it, maybe I have it, right? So if you actually Google, there is like med school induced or nursing school induced hypochondria. But we misinterpret our manifestations, right? We get on a WebMD and we look on the internet and we swipe, and it's like, oh my gosh, this could be something really important because everything on WebMD is either it's a hangnail or it could be cancer, right? It could be fatal. So we see that and we go, okay, obviously those are worst case scenario. But for someone with health anxiety disorder or illness anxiety disorder, that sticks with them and that resonates with them. And they have a compulsive obsessive thought or fear that yes, that hangnail is cancer, right? They're overly aware of everything that goes on in their body. They research all the time. They're always looking for medical opinions. And no matter what anyone says to them, you're fine, you're fine, you're fine. You still just feel like it's true. No one's listening. And so this kind of goes into two types. There's two camps that go along with this. One that we're most familiar with is the health seeking, right? Something's always wrong. There's always something wrong. Everything, like I said, every hangnail is going to lead to like death and destruction, right? And amputation. But there's also care avoidant, and that is I'm so anxious and I'm so scared that what I have is serious that I'm not going to go to any doctor, right? And so then you get these people that come in and they're in bad shape, not because it's fictitious, not because it's something that they've dreamed up and they're worried about, but because they were so worried about the worst case, they didn't treat it when it was early. Okay, so just understand there's two types when we think about this. Okay, so I'm going to show this quick little video where they talk about this health anxiety disorder. And we're going to kind of hear what they have to say. Okay, so get to the right thing here. Here we go.
If somebody watching this right now suspects they might have health anxiety or knows they're dealing with it, what kind of tools could they use to help themselves?
So yeah, I mean, the first thing is I always say to everybody, health anxiety is like a monster that stands on four legs, which is Googling, check-in, seeking reassurance, and avoidance. And by doing those four things, we're keeping the health anxiety alive. Like you can't get rid of it if we're still Googling every little thing, or we're still going to the doctors 24/7, if we're still avoiding X, Y, and Z. So firstly, you work on those. That is like the most important thing, is because people with health anxiety, they're probably Googling for like 8 hours a day. And it's like almost like you're an addict. Like I used to be in the bathroom, like Googling. So you try and work on those things, which is hard. I think it's easy for someone to say, oh, just stop Googling or just stop checking your body.
But it's a compulsion,
It's a
isn't it? So
compulsion.
how do you stop that urge? Because that is almost physical. If you've got like an urge, whether it is under an OCD heading or just this health anxiety-led compulsion, that is so hard to control. So what do you do to get through that?
Hi, everyone. Mark Barden here at St.
Okay. So looking at this and hearing them say the word compulsion, right? This goes under the somatic illness disorder, but it also is a anxiety disorder as well, right? So that is something that we have to consider, is that this is more than just, oh, I'm really preoccupied with what's going on. But it also is, I have a compulsion I can't stop. Okay. So that's the main thing that I wanted you to kind of hear. And what she said, those four things, seeking out, avoidance, Googling, constantly checking over your body, right? These are all things that we need to acknowledge with hypochondria. This next one, I will be 100% honest. I did not know a whole lot about conversion disorder. What I knew about conversion disorder was sort of like the hysteria, right? Like people would just have this sudden onset and they would like, see somebody with symptoms and they would absorb them and they would have them. So I had to do a deep dive on what this was. And what I found was really fascinating. So fictional or functional neurological disorder, conversion disorder. And that is where your body becomes like motor dysfunction. So walking, controlling your movements, controlling your speech, being able to move your body in a normal way becomes incredibly difficult. You can even have blindness, inability to speak. You can have stroke-like symptoms, right? Deafness, numbness, all of these that come on and completely upend your life. And it is all with no organic changes in the brain, which I thought was really kind of fascinating. So it's, if you did a scan of someone, their brain looks totally fine, even though they look like they are a Huntington's patient, a CP patient, a Parkinson's patient. It's all brought on neurologically, right? It's all brought on, I'm sorry, it's all brought on psychologically. Okay. There's a fact that I threw on here. You're not tested on it, but pseudocyesis is actually a type of conversion disorder where you basically convince yourself that you are pregnant, right? So it can be more than one body system affected. So this video clip, okay, so I am going to show you this one. It's a very long clip, right? And it's actually really interesting. It's a girl who was a professional dancer who basically started to lose function in her legs, and it happened very rapidly. And you'll see the video of her walking. So she went, if you watch the whole video clip, it's not very long, it's like 7 or 8 minutes. But you'll see her professional dancing on Broadway and moving her body in these like elegant, manner. And then you will see her struggling to walk down the hallway with a walker, right? And it was all brought on by nothing physical. And so if you see her in the interview, she's actually able to carry on a conversation. She is able to like actually be a functional person again, and it goes over a little bit about her treatment and the amount of work she had to do to get there, to get back to her functionality.
So the best thing I've heard from the movement specialist is he said I would probably be able to walk again. And I took that and I ran with it. When I found out there's nothing wrong with my brain, there's nothing wrong with my body, they're just not talking to each other. I was just very determined. So I started doing physio. At the very beginning, I could move my right foot along, but my left foot was getting moved by the physio. And then eventually I could kind of drag both people up. And my walking had all sorts of ups and downs. It had from trying to go up on my toes to walking kind of like I was on the moon, to not having my walk on kind of bouncing off on one wall to the other wall, quite out of control. I then got referred to Mount Vernon, which is a neurological rehab unit, and I had an amazing physiotherapist named Lisa, who I thank enough for everything she's done. She would set me up obstacle courses, all kinds of things. She would give me water glasses that were completely filled, even though I had tremors and I could barely walk, and say, walk to the other side of the room, don't spill any water. And she would give me trays of marbles to carry and not spill. She'd have me going in and out of cones and throwing bean bags. She'd throw balls at me. She'd do all kinds of things. And it seemed like the more I did at the same time, the more I could do, the more I could walk, and the more regular my movement became. I started getting better really quickly. Um, one of the hard parts was I really wanted to be able to walk upstairs. I would get to the stairs and I kind of hit the stair with my foot, and I couldn't quite get my foot high enough to step up the stairs. So we worked on that a lot, and eventually I managed to not only get my foot up onto one stair, but to walk up all the stairs. My tremors were quite hard in the way that my head kind of wouldn't stop moving. I would constantly kind of shake my head no or throw my head back, which really hurt. And Lisa would do things like put things on my head and to balance on my head, and I could kind of control it and more learn how to stop moving my head. And physio was tough, but it definitely was.
So looking at that, you can see, and I'll go back to what it actually, what we actually refer to as that fictitious disorder. So I want to go back and look at that real quick. You can see how real those symptoms were for her and how they did just completely impair and almost get her to the point where she was not functional. And it was nothing physically wrong with her brain, right? It was all a mind-body disconnection. Okay. Risk factors for this. If you look in your book, it's kind of swirly, right? Like there's not really, it could be anything, it could be nothing, basically. Again, it could be come along with some other psychiatric disorders. It can be a recent acute stressful event. It did mention that women are more affected. It did mention that it could be a childhood trauma, but basically they're not really sure, right? And that first video we watched where the sword was going through, I think that's a great visual. The sword going through the brain and the body and treating them like they're two separate parts. They're not, right? They are one. We are within the same person. And that disconnect is then what leads to this. Okay. The next one we're going to talk about is fictitious disorder, formerly called Munchausen. We talked about Munchausen by proxy when we talked about some child abuse when we were in our PEDS class. So this is a conscious decision. Okay. Then we're not talking about by proxy, we're talking about it ourselves. It's a conscious decision for physiological symptoms, okay, to constantly do that. And this is more to again, a compulsion, an anxiety. It is a brain, it is a mental health concern. But it is a manifestation that how they resolve this compulsion for um, attention, I guess, for needing to be in control of their own body is to then come up with something that isn't there. Okay. With these people, sometimes they will do it on purpose. Sometimes they will self-injure. More often than not, it is more of just a need for attention, validation, and again, getting that by doing it to someone else is called by proxy. Okay. So this is different. There is a term in your book that says malingering, and that is trying to really deceive someone for some type of benefit, right? To get out of doing something, to get something monetarily, or something free. But this is different than that. This is just attention, right? This is just emotion that you're evoking from someone is what your end game is. It's not something tangible. With this, we want to make sure we are not confronting the person and accusing them. We want to make sure that if there is any person involved that could be vulnerable, that they're safe. And this is going to need to be a team approach. If we come across someone who we think does have a factitious disorder, there's a lot of layers that go on here. Obviously, we don't want to be mean to them. We don't want to be punitive and punish them. But we are going to need to have the whole healthcare team involved so that we can all get on the same page with this person. Okay, so I'm gonna slide over here. So a couple practice questions. I know that you guys wanted more quizzes. I don't have quizzes right now. Because there is so much information. I want to add one more thing to your plate, but I am going to add some questions, right? So if a nurse is counseling several clients, which statement would we identify as a potential fictitious disorder, right? Imposed on another. So A, B, C, D. My clock is dinging here. Just a second. So A is pretending to be injured to get disability benefits. B is convincing themselves that their abdominal pain was caused by a malignant tumor. C was making someone sick so that they would be taken care of for a while, or the child would be taken care of for a while, or becoming deaf after hearing that someone had an affair, right? After some type of acute trauma. So our answer is C, right? Which is needing to make someone sick so that someone else would take care of the child or they would get attention as well. So the first one is because they're getting it for disability benefits. That would be malingering. So that's not fictitious disorder. That's not getting anything tangible. B, knowing that it's a malignant tumor, even though it wasn't a diagnosis, that would be more consistent with our illness, anxiety disorder, or hypochondria. And the sensory impairment, the sudden deafness, the sudden blindness, the sudden lack of function would be with the conversion disorder, right? Or the functional neurological disorder. The next one, a nurse is assessing a client with an illness anxiety disorder or hypochondria. Which of the following are expected for this disorder? And this is a select all that apply. So our options here are obsessive thoughts about disease, history of childhood abuse, avoidance of healthcare providers, not going to appointments, depressive disorder, or narcissistic personality disorder, right? So the answers are A, B, C, and D. And low self-esteem as opposed to high self-esteem is expected with this health anxiety or illness anxiety disorder. Last question. A nurse is developing a plan of care for a client who has a diagnosis of the functional neurological disorder or conversion disorder. Which action should we include? Okay, so they have a diagnosis. We're going to encourage the client to spend time alone, monitor the client for self-harm once a day, allow them unlimited time to discuss physical manifestations, right, or symptoms, or discuss alternative coping strategies. So which action do we want to do? And D is the one that we would be the most therapeutic. We don't want with A, we don't want them to be alone. We don't want them to be isolated. We want to encourage group therapy and support in the community. We want to make sure that we monitor for self-harm and safety continuously, right? So a time limit, I'll give you a hint, a time limit on when you're monitoring for safety. We want to do it all the time, right? Always. And we want to establish a time limit. So again, that unlimited word, right? If that unlimited word wasn't in the answer option, it might be okay. But again, establishing boundaries is a big deal when we're talking about somatic illness. Okay. So that is my shtick on the somatic illness. There is some stuff in your book. I have pulled out the most important things. Watch the video links on your own time, right? Get a feel, internalize what these things mean, and give yourself a person that like, oh yeah, that was the girl who did this, or that was the guy who did this, and that will help to make things a little bit easier. But this portion, I will you can refer to the PowerPoint, and this lecture kind of goes along with it. And this will summarize our week 2 content. Thank you.